Okay, so let's revise peptic ulcer. Etiology of peptic ulcer, which is most common, is H. pylori. It is most common in developing countries, and in developed countries, NSAIDs is most common. And for us, NSAIDs is the second most common because India is a developing country. Okay. Then stress is the cause, etiology, alcohol, smoking, bile reflexes, blood group O. That is seen that peptic ulcer is commonly occur in blood group O patients, and then steroids. Then associated factors are CRF, chronic renal failure, ascites, Cushing syndrome, Zollinger-Ellison syndrome, hyperparathyroidism, and polycythemia vera. These are the diseases which is associated with peptic ulcer. Then H. pylori is a gram-negative, flagellated, most common cause, especially in developing nations. Infection is predominantly enteral. Infection is predominantly enteral. Gastritis are of three types. Enteral predominant gastritis is duodenum, which is most common. Enteral predominant gastritis is duodenum ulcer, which is most common. Then corpus predominant atrophic gastritis is gastric ulcer. Corpus predominant atrophic gastritis, and then non-atrophic pangastric gastritic non-atrophic pangastritic is mild lymphoma. Okay. Gastric ulcer versus duodenal ulcer. Duodenal ulcer is most common than the gastric ulcer. It is a chart of differentiation. H. pylori is the cause of gastric ulcer, but here it is the very common cause. Okay. Then blood group A, it is associated with blood group A patients. So this is associated duodenal ulcer. DO, O are there. So blood group O patients. Acid. Here acid decrease or normal. Here acid increases. Acidic environment. Then bile reflux. This is here bile reflux is an important pathology, and here not much. Then smoking. In smokers, gastric ulcer is seen, and here also both. Stress, both. Family history uncommon, here it is common, means duodenal ulcer are associated with family history. Then site, crucial, this is the important, most common site here is lesser curvature near incisura angularis or prepyloric area. Lesser curvature near incisura angularis or prepyloric area, which is a point, which is the area between stomach, distal stomach and duodenum. Okay, here most common site is first part of duodenum. Then epidemiology, here less than 5% cases, here more cases are involved. Duodenal ulcers more common, more cases. Malignancy 1 to 2%, this is malignant, and here always benign. Duodenal ulcer. Clinical features: pain after food, this is the most differentiating factor in here. Pain after food means after taking food pain occurs, so the person avoids eating food because it will be a reason for pain. So the person is thin or weight loss occurs here. Here pain occurs before food, relieved by food, milk. So weight gain occurs. Night pain, here it is common because increased acid production, and pain at fasting. Then diagnosis of H. pylori are of two types: invasive and non-invasive. Okay, so in non-invasive, first we see urea breath test. In category of non-invasive, it is most sensitive and specific test. Then second is stool antigen test. These both, urea breath test and stool antigen test, are both used for follow up after 4 weeks of therapy. Means we have given therapy, and then after 4 weeks of therapy we do these tests. After this, because they will inhibit, they will be negative only when bacteria die eradicate. That's why follow up after treatment. Then third test is serological test. Use of IgA antibody, immunoglobulin, IgA immunoglobulin can't differentiate between active and chronic cases. Yeah, this is not important. Serological test, because it cannot differentiate between active and chronic cases of H. pylori, but this is used in epidemiological survey because it's a quick test. Then invasive tests are also of three types. First is endoscopy based on urease test. Then second is histology, which is the most accurate test. Endoscopy based biopsy, in which it gives Worthy or starry appearance. Then third is culture. Then question: drug to prevent NSAIDs associated pudipeptic ulcer is mesoprolol. Prevent is mesoprolol, and treatment is drug of choice pantoprazole. PPI not safe in pregnancy is lansoprazole, and which is safe in pregnancy, it is omeprazole. Lansoprazole is not safe in pregnancy. Omeprazole is. Sites for peptic ulcer. Duodenum is the most common site, then stomach antrum, then gastroesophageal junction, then margin of gastrojejunectomy, then Zollinger-Ellison syndrome, then Meckel's diverticulum. Complications. Most common complication of PUD is hemorrhage, in which two types of melena and hematmesis. Melena is black tarry stools, and hematmesis is gastroduodenal. Hematmesis is vomiting of blood, bloody vomiting. The commonly artery involved is gastroduodenal artery. Second complication is perforation. Then, in which severe pain occurs, cupula sign is the air beneath the diaphragm, which looks like a mustard. So mustard sign, also called as mustard sign. And third, due to perforation, severe pain, cupula sign, board-like rigidity is present. And third is malignancy, and fourth is gastric outlet obstruction. We will see it further. Gastric outlet. What is gastric outlet obstruction? Stress ulcers are of two types: Cushing ulcer and curling ulcer. Curling ulcer. Remember this by like this. Curling. We do curling of our hair by burning it, like that Philips curler. So it provides heat. So curling ulcer occurs is due to burn, and Cushing ulcer is due to, like in meningitis and all, increased intracranial pressure occurs. Cushing ulcer. To provide Cushing, Cushing ulcer provide Cushing because intracranial pressure is increased. Treatment is triple therapy: 2 antibiotic and 1 PPI. Clarithromycin or metronidazole or penicillin are the antibiotic, and PPI used is omeprazole mainly. Quadruple therapy is 2 antibiotic, 1 PPI, and bisubsalicylate. Bisubsalicylate it helps in makes a coating over gastric mucosa. It makes a coating over gastric mucosa, so ulcer don't occur. The two antibiotics are metronidazole and tetracycline. PPI is omeprazole. Pyloric stenosis or gastric outlet obstruction, which is a complication of bleeding. Pyloric stenosis or gastric outlet obstruction. Age in infant, it occurs usually, especially the first male child vomit milk, which is given in the morning. Adult vomitus consist of 1 day before food, you know. Then in child, dehydration occur and hypochloremic alkalosis occur. Loss of H plus. Metabolic alkalosis with aciduria. Urine is acidic, but in body, because acid is secreting in through urine and the body becomes alkaline. So metabolic alkalosis with aciduria, hypochloremic alkalosis, loss of H plus. Okay, loss of H plus acid in urine and hypochloremic alkalosis. Okay, in investigation of choice here is barium studies. Treatment is rehydration with dextrose, saline or potassium. Means first line of treatment is rehydration only. The second is pyloromyotomy, which is the removal of pyloric point, which is called as Ramsted operation. Then malabsorption syndrome. Malabsorption syndrome, this is the proximal part, and this is the middle part, and this is the distal part. Okay, in proximal part, mm, duodenum means the middle is jejunum and distal is ileum. In proximal part means duodenum, fats, folate, iron are absorbed, sugar, amino acid, water, electrolyte, and calcium is absorbed. In middle, jejunum, folic acid, and all. And then, okay, here fat, folates. In middle, sugar, acid, amino acid, water, and electrolyte, calciums are absorbed. In distal ileum part, bile salts and vitamin B12 is absorbed. Then iron is absorbed in ferrous form and stored in ferric form. Ileum, if ileum is resected, B12 deficiency occur. If jejunum is resected, fatty acid deficiency may occur. If duodenum resected, iron stores is decreased or deficiency occur. Iron deficiency occur. Then celiac disease. This is a gluten sensitive enteropathy. Here, this is autoimmune. Here, wheat, rye, oats, and barley are not given due to them because they contain gluten. Due to them, celiac disease. Then etiology is non-infectious but systemic features occur. It is non-infectious. It is non-infectious. Obviously, it is autoimmune, but the systemic features here occurs. Okay. Clinical features of malabsorption syndrome are steatorrhea, fat loss in stool, weight loss, chronic diarrhea, anemia, growth retardation, abdominal distension. Abdominal distension means food is not being absorbed. It is abdomen is distended. It is full. It is fat. It is not going in after some time. It is not digesting. Food is not digesting. Investigation of choice is biopsy. In celiac disease, investigation choice. Biopsy mean here the height of villi decreases, villus atrophy, villi get atrophied, then no mucosal atrophy, then increased lymphocytes, cuboidal appearance of epithelial cells. Proximal intestine is more affected in celiac disease. Okay, proximal means the duodenum and that part. Then antibodies which are involved in celiac disease. Anti-endomysial antibodies is most common. Endomysial, increased sensitivity. Okay, then after that, anti-TGA, anti-tissue glutaminase antibody. It is more specific, glutaminase. Then anti-reticular antibody, and then anti-gliadin antibody. Okay, fat soluble vitamin decreases here. Fat soluble, because vitamin A deficiency leads to nyctalopia. Vitamin D deficiency leads to bone pain, because proximal part of a small intestine is affected. So vitamin A deficiency, fat soluble vitamins are decreased, bone pain, growth retardation, etc. Vitamin B12 deficiency is least, because it is in iliac, it is absorbed in iliac part of the intestine. Other are uncommon, like E and K, because K is less common because it is synthesized in the body. And celiac disease is associated with diabetes mellitus and dermatitis herpetiformis, any other autoimmunities. We all know that any autoimmune disease is also associated with other autoimmune disease. So here, any autoimmune disease can occur. Most common cause of death is lymphoma in celiac disease. Lymphoma is the most common cause of death. Treatment: gluten-free diet like rice, corn, millet, tapioca means sabudana. Then Whipple disease, infectious etiology plus systemic features. Here, etiology is infectious plus systemic features. Okay, the causative organ is Tropharema whipple. It is an intracellular organism in macrophages. It is an intracellular organism present in macrophages. Okay, inside the cell it is present. Malabsorption features, because it is systemic, so malabsorption features are present, like fever. Because of infection, fever, lymphadenopathy, arthralgia are also present. Then in CNS, dementia is most common. Then seizures, cranial nerve damage, cranial nerve 3. Then characteristic, yes, this is the main point to remember. Characteristic histopathology. Investigation of choice is biopsy. And characteristic histopathology finding is PS positive macrophages. PS positive macrophages in Whipple disease. PS positive macrophages. Lipid blockage, then lymphocyte and eosinophils are increased. Lipid blockage occur. Then tropical sprue. In this, patient gives a history of traveling to foreign country. Infectious, it is infectious, but without systemic features. Here, systemic features are not present. Etiology is E. coli most commonly, then Klebsiella also, and giardiasis also. Biopsies: shortened villi, increased crypt depth, infection by mononuclease. But these features are not characteristic. Clinical features are chronic diarrhea, malabsorption, weight loss, etc. Then difference between celiac disease, Whipple, and tropical sprue is it is non-infectious and but systemic features. It is infectious and systemic features are present. Infectious and non-systemic systemic features not present. Non-systemic. Then histopathology in celiac disease, villus atrophy, and not mucosal. Villi get atrophy, not mucosal. Then here it is characteristic histopathology finding PS positive macrophages, and here short villi, increased crypt depth. Okay. Then etiology, celiac disease autoimmune, Whipple disease is caused by Trophanema whipple, and tropical sprue is caused mainly by E. coli. The malabsorption. Specific characteristic biopsy, Weber disease, Crohn's disease. Non-specific biopsy, celiac, tropical sprue, and Zollinger-Ellison syndrome. Crohn's disease में we will see it later. What is the specific characteristic biopsy? I guess cobblestone appearance. Yeah, cobblestone appearance is the specific. Then steatorrhea is a greasy bulky stool in which fat is there. It occurs in malabsorption and pancreatic diseases. Steatorrhea occurs in malabsorption. We have seen. Definition of steatorrhea is excretion of more than 70 gram of fat in stools during 24 hours when patient is on a diet of not more than 100 gram of fat. In 70, more than 70%, he or she is losing fat in stool passing. And what is D-xylose test? D-xylose test is absorbed in proximal intestine. Proximals mean in duodenum without help of pancreatic enzymes. D-xylose absorbed in proximal part of intestine without help of pancreatic enzymes. Okay, so to understand this, there are two people in which D-xylose is given. In the first person, in blood and urine, D-xylose is very very less in amount. So we can conclude by this like that we have given D-xylose, but in blood and urine it is not coming out. So we can conclude by this like the person has some intestinal problem like celiac disease, tropical or Whipple's disease. But if we have given D-xylose and it is coming in urine and blood, then present in adequate amount, absorption in intestine is perfect. Absorption is perfect, but means intestine is perfect. Absorption is occurring, but why steatorrhea in these? But it is coming in urine and blood, na? So because pancreas are bad, it is occurring because pancreas. We have seen the steatorrhea cause is malabsorption, also pancreatitis. So by xylose test we can conclude this. Okay, then false positive in these cases. D-xylose test comes false positive, means it is bacterial overgrowth syndrome, renal insufficiency, ascites, pleural effusion, antibiotic therapy. Then blind loop syndrome or bacterial overgrowth syndrome. Okay, here stagnant bowels or stagnant bowel syndrome. Here bowel is stagnant. Causes are functional stasis in diabetes mellitus. Strictures direct communication between large and small intestine. Enterocoliac anastomosis, direct communication between large and small. Here bacterial overgrowth syndrome can occur in these three cases. Strictures enterocolic anastomosis, and functional stresses. An investigation of choice here is jejunum aspiration culture. Jejunum aspiration culture. From jejunum, we aspirate some culture and then do the diagnosis investigation. Symptom: decrease vitamin B12. Okay, decrease vitamin B12. Here in investigation, jejunum aspiration culture, if more than 10 to the power 11 10 to the power 11 microbes are present, and diagnosis is confirmed. Symptom is decreased B12 and treatment is broad spectrum antibiotic. Initialing test is a test for vitamin B deficiency test. Here in these 4 cases vitamin B12 deficiency may occur. So if in first we will give patient intrinsic factor. If vitamin B12 improve, if check for vitamin B12 by in minute by cobalt 58 labeled or radio labeled cobalamin comes in urine. If this radio labeled cobalamin comes in urine, then he has pernicious anemia. If it does not come after giving intrinsic factor, then we give exocrine pancreatic pancreatic enzymes. If cyanocobalamin radioactive comes in urine, then we can diagnose that it is pancreatitis. If it is not coming, then we give antibiotics for 5 days. If radioactive cyanocobalamin comes radio labeled cyanocobalamin comes, then it is bacterial overgrowth. If still it does not come, then we can diagnose it as celiac disease. For celiac disease, by the way, biopsy is the main investigation of choice. Fat malabsorption test are these two. Just we have to learn these. Fat malabsorption test, triacetanoin breath test, and tripalmitin breath test. Okay, but then this fig here. To both solids and only solids. This fig here. Both solid and liquid is achalasia cardia or esophageal spasm, and two only solids are malignancy strictures of Webb. For both, first diagnosis is barium swallow study, but to differentiate, second diagnosis for a solid and liquid both is manometry, and here it is endoscopy. Then Barrett's esophagus. Barrett's esophagus is when the esophageal squamous epithelium is replaced by columnar epithelium. It is also called as intestinal columnar metaplasia. Most common site is lower esophagus because of GERD. In males, it is more common. Clinical features are odynophagia, painful deglutition, which is weight loss, heartburn. Okay, then diagnosis gold standard here is endoscopy or biopsy. In here it comes salmon pink epithelium is present. Then it is a pre-malignant condition. Complication is very important of Barrett's esophagus. It is adenocarcinoma and strictures, thickened structures. Okay, adenocarcinoma and strictures. Then here treatment is PPI or photodynamic therapy. In photodynamic therapy, we give something chemically, and then we can see the part which is metaplastic, and then we remove it. Then achalsia cardia. This is lower esophageal sphincter and this is upper esophageal sphincter. Lower esophageal sphincter normally is it is constricted. It is always tonically active, means constricted, but when food is passing through it, it gets relaxed and do its work. In achalsia cardia, lower esophageal sphincter not able to relax, has increased tonicity always. Even when food is passing, it will not able to relax. So the upper portion will bulge like this. It will look like beak shaped deformity because it is not opening. Okay, then clinical features are dysphagia, more for liquids than for solids, because solids have gravity and they are little heavy, so they will apply pressure and can pass through, but liquids cannot. Liquids will bulge like here and accumulate there. Weight loss. In clinical features, weight loss, heartburn, GRD. Malignancy may occur. In malignancy, squamous cell carcinoma may occur. If achalsia cardia is persistent, then malignancy can occur. Then aspiration pneumonia can occur. Treatment is muscle relaxant because it is tonically active and constricted, so we have to relax it, so we'll give muscle relaxant. Then botulinum toxin we can give, and then surgery. Hiller's myotomy is the surgery name. Plummer-Wilson syndrome, we all know, esophageal valve, iron deficiency, anemia. Females, it is more common. Coelonchia, glossitis is also called as Patterson-Kelly-Brown syndrome. Then here two things are there: Mallory-Weiss syndrome and Boer-Haave syndrome. In Mallory-Weiss syndrome, first let's see, this is gastroesophageal junction tear. Here gastroesophageal junction will tear. These both have the same etiology, chronic alcoholism. Okay, then so due to alcohol, gastroesophageal junction will tear and causes hematemesis, chronic coughing, vomiting, alcoholism, superficial tear. It is in bulimic patient. These are the clinical features of Mallory-Weiss syndrome. And then Boer-Haave syndrome is more severe, also called as McClure's triad. Here emphysema, hematemesis and pericardial pleural effusion and pain may occur. Here muscle, GIT muscle may tear, deep tear. This is superficial tear and this is deep tear. Then diffuse esophageal spasm, uncoordinated movement,